Welcome to the Urology webinar series, where knowledge meets collaboration to improve pediatric urological care. Today, we come together to explore the challenges, breakthroughs, and opportunities in managing urological conditions in children. Urological conditions in children can affect the kidneys, bladder, and genitalia, often from birth or early childhood. Without timely recognition and treatment, they can impact growth, development, and overall well-being. But the good news is, many of these conditions are highly treatable when identified early. Through this webinar, we'll share expert insights, practical strategies, and real-world experiences that empower clinicians to deliver better outcomes together. Thank you for joining us today. Let's get started.
Yay! Good evening, colleagues, and a warm welcome to the Clinical Care Platform, your home for continuing professional development. I just want to say thank you so much for joining us this evening and importantly, trusting us with your professional development. As a platform, we have a mission, and our mission is not very complicated. All we want to do is to improve patient care, and we literally do this by enabling you to have access to updated evidence-based education so that you are always informed, you are always updated, and you are always in a position, to respond appropriately when some of these conditions present. Just to remind you as well, we are a membership-based platform. Most of our webinars are CPD accredited. If you attend successfully within 48 hours, you should get your certificate, but also your CPD is being locked with your professional counsel. It could be the HPCSA, the nursing council. We have so many councils, so I'm not going to list them. Just to say that today we are focusing on children and we are going to be looking at urological conditions. This is one of the topics which we hosted with our first cohort in the Diploma Child Health, and I saw it befitting that we must bring this awesome knowledge to the general audience yourselves. So I hope you are as excited as I am, because we do get feedback that as a platform, we are not doing a lot on pediatric or child health. So it's very, very exciting. But before I start, let me see who is here. Patrice, welcome. Abdul says good evening. Dr. Dede there says good evening, colleagues. Nokwanda says good evening. So people are ready, people are happy. I'm just encouraged, by your commitment for professional development. And when I see you, I don't know what you could be doing, with your time this evening, but just seeing you committing to be here with us, I think, it leaves me speechless. I would be blushing. Like I always say, my skin is too dark to blush. Otherwise, I'll just turn all gray. Judith, welcome. So, colleagues, I am never alone. When I come here, I always bring ammunition. So, today I'm with our dearest urologist. He's not new to the platform. He has already done a number of educational programs, and I've also invited him to some of the diploma programs. Dr. Peter of Lion, who is a qualified medical practitioner, but who also has an M.Med in urology from UKZN, but is also a fellow of the Colleges of Medicine of South Africa. His focus is on minimally invasive procedures and evidence-based practice, and he further trained in minimal invasive surgery in Orlando in the USA. I mean, he can treat everything because he has been empowered to do so. But let me tell you, he had his first talk here, and I just enjoy the way Peter teaches. You would even think it's something, Peter, that you do, like maybe on a weekly basis, the way you are so comfortable, But he's currently practicing at the Netcare N17 Hospital in Springs, and also in Busamed Hospital, offering advanced and compassionate care using the latest technology. So it's such a great honor, Peter, to host you. All I want to say is that welcome back home, and I can't wait for you to start. Can I hand over to you? Welcome, brother.
Thank you very much, Lesego. Good to be here again. Thanks for the invite, and I'm happy to share my knowledge, updated knowledge on the topic.
Thank
Hopefully,
you.
hopefully everybody's going to enjoy it. So I'll try and
Welcome.
share my slide now so that we can begin.
Awesome. Awesome. Colleagues, as Peter shares his slides, I wanted to say that we are growing our LinkedIn presence because it's a place which can also benefit you professionally as you get your credential certificates from CCP. Please share them. I've shared the link there. Just click it, go to LinkedIn and say like, and share on your profile. Let's grow your career together. Yeah, on that note, let me hand over to Dr. Peter. Thanks, brother.
All right. Thank you. Good evening, everyone, and welcome to today's webinar on urological conditions in children. Basically giving an overview of what you see most commonly. Obviously, there's more topics, but the regularly encountered ones and quick practical way to approach it, and more importantly, when to refer so as not to miss some important conditions and management. All right. So Peter Afolaine, specialist urologist here in N17 Busamed in private practice. So today's topic, let's see, we basically want to go through those urological conditions, identifying the red flags, and what diagnostic approaches, and especially the initial management, if it's an emergency, how to stabilize the patient before referral. And I'd grouped it into your congenital anomalies, which you probably see more in the infants, and in some cases in setups where you have pediatric surgeons. A lot of these kids do get seen by pediatric surgeons before they get to urology. However, as they grow out of it, with the condition, still a lot still end up with the urology, or if you have a dedicated pediatric urologist. So there's the functional issues when it comes to voiding disorders as well, which is more of like a physiological dysfunction of voiding, which we'll go into the different types of infections in pediatric urology and the emergencies that you normally encounter as well. Under congenital anomalies, I think hydrocele is quite common. Undersanitase is also quite common, hypospadias. And as we go into posterior urethral valves, these do happen, not necessarily presenting to the normal OPD. However, you need to be mindful of patients who presents with difficulty in urinating at an infant age or even in a neonatal state. Your children with recurrent infections, but the cause would be maybe coming from a reflux, kids with PUG obstruction, and somewhat duplicated renal system, collecting system. So getting straight to most commonly seen condition, an undescended testis. Undescended testis, I mean, it's a lot of kids, it doesn't get picked up initially because at birth, it might still take up to 6 months before complete descent of the testes. So you do have a child that maybe the mom brought in at 3-4 months that they're not able to palpate the testes. You wait 6 months to see if it eventually descends into along its path into the scrotum before deciding whether to be concerned or not. The way it will present is it will be an empty scrotum. Sometimes it's easily visible, like in this kid here, where you can see that okay, only one part of the scrotum is developed. The other might be hypoplastic. And when you palpate, you only feel one, or in some cases bilateral, when no palpable testis is found. If you palpate further, you might be able to feel it in the inguinal canal, which is where it commonly 80% of undescended testes coming along this normal tract will be in the inguinal canal. Sometimes it's not easy to feel it because of the age of the child and not being stable when being examined, and a lot of it uh, uh, when the patient actually needs correction, then you're able to palpate it under anesthesia when the child is more relaxed. Treatment, we usually, after the 6 months when the diagnosis is made, you want to get to treating it early within between 6 months and 18 months or max 2 years due to risk of you want to prevent infertility later on. So after 6 months, undescended test is referred to a urologist. So the picture just shows the different sites in which the testes could be. So you want to palpate as far as all those region. You do get ectopic testes, which is not coming along that tract, and it's maybe in the penis or in the thigh. Those are easy to miss because that's not the area one usually palpate. But by the time they get referred to us, we'd still look at all those sites before going for imaging to try and find them if they're not along the tract. So yeah, basically after 6 months, refer to urologist, and what we do is we assess and decide whether the patient should have correction now or give it another 6 months. The reason we wait, we want to correct it early so that early orchidopexy, which is bringing it down to pexy it in the scrotum, it helps preserve germ cell development because germ cell development is still taking place up to that age, and therefore increases or decreases the risk of fertility on the child later on. Okay. In children going through to teenage years, because a lot of them will pick it up late, like he's already 6 years old, undescended testes. Should you do acutopexy? Then yes, sure. Because even though you might have missed that fertility risk chance there, but you want the testes to be in its natural position in the scrotum so that the risk of malignancy, especially seminoma that's already present, should it happen, it's palpable. So you want to be able to get the testes into the scrotum by the age of 12, 13 preferably. So it is ideal to still refer the patient even though the patient is like 6, 7, or 8 years old because there's still chances of preventing not preventing seminoma, but being able to detect it if it does happen. Hydrocele is another common presentation in pediatric urology, which the parents will just complain that one side is more swollen than the other. And I mean, you want to differentiate between is that fluid or is that bowel or omentum? Is it a hernia? And to do so, basically, hydrocele is having fluid accumulating around the testes in the tunica vaginalis. That's the sac that's protecting the testes. And if you shine a light on that swelling, if it transilluminates, you know that it's fluid that you're looking at, compared to if it doesn't, then you're thinking maybe it's other solid structures like bowel or so. And it will present as a painless scrotal swelling. And like I said, key clinical diagnosis, does it transilluminate with light or not? Clinical examination, you can make the diagnosis, but if you're not sure, do an ultrasound at the bedside or send for formal ultrasound to just check whether that's fluid and to see whether it's a communicating or non-communicating. Because if you push it further up and it drains up into the abdomen, that's a communicating hydrocele. If it's non-communicating, it just remains to the sac. It means the fluid accumulated in the tunica, but the process vaginalis had closed, so you're not really getting returned back into the abdomen. In some cases, a child less than 1 year with that hydrocele, you can observe to see whether the patent process vaginalis eventually closes, which then does not allow for further drainage into the scrotum. But if it persists, then refer accordingly so that surgical intervention can be done. So usually after a year to 18 months, and or if it's increasing in size, then you can refer. But less than that, don't panic initially. Reassess the child to see whether it's still persistent or it has disappeared. Hypospadias, that's when you have the urethral meatus, which is a pee hole, not located where it should be centrally on the glands. and it could be anywhere along that mid penile to scrotal raphe line, and you can have it as a distal hypospadias, mid or proximal hypospadias. Obviously, the more distal it is, the better it is to repair or not repair, because indication for repairing is if there's splaying of urine when the patient pees, or if it's a bit distant, I mean, if it's a bit mid or proximal, because you worry about later on in life when it comes to fertility in terms of sperm reaching where it needs to reach. But otherwise, for a lot of the coronal hypospadias, that does not clinically affect the patient. It does not necessarily need surgical intervention. You do get urethral meatus opening elsewhere outside of well, the penile part, opening by the perineum or in the scrotum. Those will need surgical correction. It's commonly associated with the curvature, ventral curvature, which we call a CODI, and sometimes having a foreskin, like a hooded foreskin, that is not a complete foreskin as well. So when it comes to correcting the hypospadias, you want to probably correct the CODI first before going for the full hypospadias repair. So some of these patients might need more than just one procedure done. So it's on examination, one can pick that up either at birth, although some patients will have physiological phimosis where the foreskin is tight and you're not able to pick that up initially and only pick it up later on as the phimosis reduces. In a case where you find that there is hypospadias, the patient is not for circumcision. A lot of the referrals come from the general practitioner where maybe they wanted to circumcise the child and then they pick that up, which they know to not circumcise because that foreskin might be used as a plate, as a urethral plate when it comes to surgical management of hypospadias. So if picked up early, it can be repaired between 6 to 18 months of age, but at any age where it's picked up, one is still able to refer the patient accordingly for hypospadias repair. And again, the aim is mainly functional and cosmetic restoration. So if picked up early, pediatric urologist or ped surgeon, later on, just a urologist is fine. Posterior urethral valves, the patient will present with poor stream or having recurrent UTI or always having a palpable abdomen, failing to thrive, and making the diagnosis here, you can see it on either on an ultrasound or when they do a cystogram or a voided cystogram, and we see that keyhole looking sign.